supportive care and outpatient management. And I'll turn it over now to Dr. Sandrine Nianger from University of Maryland.
Good afternoon. It's such an honor to be invited to be a member of one of the panelists on this talk. So my name is Sandrine Nianger. I'm one of the hematologists at University of Maryland, where I focus on patients with bone marrow failure disorders. I help diagnose, give prognosis and treatment for patients with bone marrow failure. I help run clinical trials at University of Maryland. And then I also conduct research in the laboratory looking for new therapies, along with assistance with referring my patients to help get them through stem cell transplant. And my goal is to provide comprehensive and family-oriented supportive care and outpatient management for every single one of my patients at University of Maryland. And so I'm going to turn it over to Jennifer Lauder and Anastasia Santiago to introduce themselves.
Hi there, I'm Jen Lauder. I'm a physician assistant at the NIH, and I work with Dr. Neil Young and his colleagues, Dr. Groark, Dr. Patel at the NHLBI, the National Institutes of Health, and I've been there, oh gosh, about 8 years now, and I manage bone marrow failure patients that come to the NIH for second opinions and to enroll in our clinical trials, really from all over the world. So I see patients all over the US, I see adult patients, pediatric patients, and patients that are international as well.
And hi, I'm Anastasia Santiago. I'm a nurse practitioner at the Sylvester Cancer Institute with the University of Miami in South Florida. I work primarily with MDS. MDS overlaps in acute and chronic leukemias here at Sylvester, and that's both with standard of care in clinic and also with clinical trials that we have available at the university. Thank you for having me.
Okay, so today we're talking about supportive care and outpatient management for patients with bone marrow failure. I'm going to share my screen really quickly. And as I kind of talk about, my thoughts on supportive care and outpatient management for patients with bone marrow failure. So what is supportive care? I see it as a way to improve quality of life by preventing or treating as early as possible the symptoms of the disease and the side effects, all the side effects from the treatment, as well as the symptoms from the disease itself. And this includes physical, psychological, social, and spiritual support for patients and their families. I feel like traditionally we focused on the patient, but now we're starting to see how important it is to focus on their families. So traditionally, we were always so focused on making sure patients are getting their blood transfusions, making sure they're on the right medications, that we're getting them through their chemotherapy treatment or their immunosuppressive therapy, the side effects, the nausea, vomiting, prevention of infection, which is critical, and then supporting them through the stem cell transplant, including finding a donor, and then the itty-bitty things like managing catheters, ports, PICC lines. But really, supportive care is actually, to give effective care to patients, it's really much more holistic and comprehensive. It's, pain management. In the past, we really didn't focus on pain in our bone marrow failure patients. Pain as a complication from the treatment as well as from the disease, and making sure we're carefully assessing their pain. Another thing we often don't think about is the nutritional support. Often not even discussed, optimizing your diet and nutritional health. The next part that was often, omitted was counseling and support, dealing with the stress, anxiety, depression, and shock of this diagnosis, not just for the patient, but for the family and the caregivers, and the importance of our caregivers. We now have caregiver support groups and caregiver relief programs, which we didn't have in the past. Making sure that all patients are receiving psychological support to help patients cope with their emotional difficulties with the diagnosis of a bone marrow failure. It's important, and it's important that we include this, a family-oriented support to help patients and the family find ways to support each other through this, challenging and rigorous treatment. The other part is exercise. As oftentimes as physicians, as providers, we don't even think about exercise. No, I'm not talking about CrossFit. I'm talking about just things like yoga and doing daily walks, which can strengthen not only your body, but your spirit and mood, improving your overall well-being. Music and art therapy is an amazing part of supportive care that could really help with the counseling support, the managing the psychological stress of this diagnosis. Meditation, another way we can support our patients, and then financial counseling. The cost of cancer care is just rising rapidly right before my eyes, and it's so important that we are not addressing not only the care and management of their bone marrow failure, but also the financial toxicity of their treatment. And then something we would often completely not address until we reached a point, which is palliative care and advanced care planning. Assistance with end-of-life decisions, such as creation of advanced medical directives, determining whether it's going to be at home or other type of setting that will be best for you and your family to ensure continuity of care. These are things that we often ignore, but actually plays a role in providing comprehensive care. And so, like I said, supportive care can be given with other treatments from the time of and it's going to be given throughout your treatment to help. And so there's so much barriers to care for bone marrow failure patients. Lack of social support, including lack of consistent caregivers and transportation. And I know definitely in my, care, COVID-19 and the pandemic really exacerbated this, along with, insurance and financial concerns. We always think about the cost of medications, but things we don't think about is the high out-of-pocket costs, co-payments, and then things like paying for, parking and so forth. And it's shocking. Research just recently published that a majority of cancer patients and survivors struggle to afford cancer care, and over 80% have to make financial sacrifices to cover for their healthcare expenses, which is unbelievable. So, addressing the financial care, toxicity and care with treatment of bone marrow failure is crucial. And then the last part is problems with healthcare communications and care coordination, which we just talked about before. So a lot of patients are seeing, physicians at a specific institution, and then they have their local doctors, and making sure that the teams are communicating effectively can be so important to outcomes. And so there's, these barriers can really make an impact on care. And so it's important to address barriers to care. And, some of the things that we've done is the patient navigators. They're so crucial. The patient navigators are that in-between between the patient and their family and the healthcare provider. They help patients navigate the healthcare system. A lot of these institutions are massive, and we never know who you need to call. And so having one person that you can just go to who can then help you navigate the healthcare system is so important. And then, another issue is, transportation. And so, we are finding that there's new programs to help with transportation, and then having a multidisciplinary visit. At our institution, we're having one visit where the patient sees all members of their team, and that is so important to just, instead of having to do multiple visits, especially in patients who are, driving or flying from far away, just coming in and being able to meet everyone at once is really important. And then, like I said, personalized care targeting each patient's unique situations. And so for the financial toxicity, there's so many financial toxicities to cancer care that can, impede care. It's shocking, whether it's, difficulty returning to work. A lot of our insurance is tied to patients' jobs. So if you cannot go to work, you may lose your insurance, and then how are you going to pay for this treatment? There's so many things that can really help. And so, we've started having financial navigators. Hospitals are now, advertising how much things are costing, meeting with the social worker from the beginning and applying for a lot of these grants and programs. And then, like I said, aggressively applying to these copay assistance programs from different manufacturers to bring down the cost. So here's a list of some of these financial resources for patients. Aplastic anemia and the Myelodysplastic Syndrome International Foundation, AAMDS, they do these, conferences, and they always talk about the different resources that patients can access. And like I said, working with your provider and the social worker and the patient navigator to help you maximize all of your resources. And so ultimately, I think it's important to speak up and always ask questions, and it's going to take multiple providers from different backgrounds to provide effective, comprehensive care. And so I'm going to turn it over now to I'm going to stop sharing to our speakers.
I can kind of speak to what you said. My situation is unique in that at the NIH, all the patients that we see are on clinical trials, and they don't have to pay for their treatment at the NIH, but oftentimes we refer those patients back into the community. So we are definitely seeing some of these challenges often. So I do have some slides I can share. Give me 1 second. Can you see my screen?
Yes.
Okay. So this is me, Jen Lauder. So I work primarily with aplastic anemia in the bone marrow failure setting, although we do see some MDS patients as well. There is another team that manages bone marrow transplant, but I'm involved in the handoff to that team when necessary. And we kind of discussed the barriers to care, but it's multifaceted. There's the financial hardships. At the NIH, we treat patients from other countries that don't have access to insurance at all, just accessibility issues, social issues such as caregiving, and just the rarity of the disease. This was something that came up a lot in the survey results that we were lucky enough to have shared with us prior to the presentation, but just the lack of specialty knowledge. Not all hematologists, oncologists are familiar with bone marrow failure syndromes. So it can be challenging for a diagnosis or getting referral to the exact resources that you need. And I go into that a little more detail in the outpatient setting. So this is for patients that may have had their inpatient immunosuppressive treatment and are now out in the community. And transfusions is really one of the big burdens, especially if they're not responding to treatment or they're in the initial stages of diagnosis. And just the frequency, patients that have bone marrow failure need to come in twice a week for platelets, and that can be very stressful. Finding matched donors, that's something we've had challenges with, that not all community facilities have the tools to match for HLA antibodies to give appropriate products to patients. And then the complications from having a lot of transfusions, so iron overload. And just kind of managing all those things. And then lab monitoring, so the availability of lab tests. So some of the studies that we have require monitoring for therapeutic levels of drugs, and that becomes a send out test for many community hospitals, and getting those in a timely manner can really affect the care for the patient. And one thing that I've noticed since I started 8 years ago to now is we've really come up with a plan of treatment that is successful. So we're looking more at these long-term care of these patients. So monitoring them over time when they're doing well, and taking a look to see, if and when they relapse. The big question is this a relapse? Is this a temporary depression of counts? Do we retreat now? Do we refer to bone marrow transplant? These are all questions that come up in the outpatient setting. And, what comorbidities do these patients have that make them eligible for any of these secondary treatments? And managing side effects, this is something that I do often with community physicians and advanced care providers when patients are being treated on clinical trial, because they're not used to using these types of drugs. So these very common things that we see with like cyclosporin, like gum hyperplasia, it becomes an issue of really coordinating your care with other specialists and talking to them about the disease and what to expect. Because for example, I've had a lot of dentists want to laser off gums, and I'm like, no, don't, it'll get better. And that these are temporary side effects due to the medication that'll improve over time. And of course, just bleeding complications, making sure that you're maximizing the medical treatment there. Drug side effects, making sure you're aware of any toxicities of any new drugs being started. It's a group effort. And I think that communication is key. There needs to be a really tight knit group of communication with specialty providers. One of the things that I've noticed a lot is women with aplastic anemia specifically, and the struggles that they have with managing their menses or with pregnancy. And it's really, there's not a lot of literature there, and just trying to work with their providers to stop bleeding. For example, when platelets are below 10,000, it can be a multi-step process. And rare diseases are tricky. This has been a very common theme today. It's difficult to get access to the experts who know about this disease. But at the NIH, we are at least trying to train advanced care providers in addition to physicians, so that when they go out into the world as providers, that they have knowledge of more of these rare diseases. And for patients living in more remote areas, more rural communities, even referral to an academic medical center just for a second opinion could be beneficial. And financial hardship, this is always tricky, but looking into social work assistance, looking into patient assistance programs, this is something we even do at the NIH, is just, especially for PNH patients, we will contact the pharmaceutical companies and apply for compassionate use of their medications for patients that can't afford it. And tapping into community resources like the AAMDS Foundation. And we talked a little bit about this too, accessibility, lack of transportation, how expensive it can be. This is a constant struggle for everyone, really, because it's just so difficult to get from one place to the next. And, sometimes this involves multiple centers. You go to your provider, the transfusion center somewhere else. It's, trying to find someone to assist in all of that. It's difficult. And then social issues, not everyone has time off from work. The burden of time to get transfused and get multiple labs drawn and get treated is substantial. And these patients may be a caregiver to children. They may have caregiver responsibilities to other members of their family. So these are all things that need to be taken into consideration. And the one thing I did want to touch on, just because this is my wheelhouse, is clinical trials. So clinical trials, it was discussed at an earlier session that part of it's just education and getting past the barrier of the stigma of clinical trial and what that means to certain populations. But every clinical trial is different, and what they're looking at does touch on more, some of them are more experimental than others. So it's important to know the difference there. But I do want to just point out that clinicaltrials.gov is probably a resource that anyone can go to just see what's out there. And the first step is just looking there and search any trials recruiting for the disease that you may have. And then you could speak to the research nurse or coordinator and see if you would be eligible and come on site for a visit. And I just wanted, this is just a screenshot of what it looks like. So you would just put in your condition or disease, and then it would come up, and I selected recruiting, but you would see a list. And this is actually all international trials for aplastic anemia. And there's 51 studies recruiting internationally. And that's it. Just a beginning start of the things I see. And I know that my situation is a little bit different at the NIH, but we do work very closely with the community as well. So I'll hand it off to Anastasia.
Thank you. I don't have slides to present, but I'll just speak on my end about what I do at Sylvester and what we do to address some of these barriers. Here in South Florida, we are considered a melting pot of many cultures, many different populations, and we get immigrants into our community from all over the world. We have patients that we see from South America. We have patients that we have from the Caribbean who come, get treatment, see us in office, and fly back home. And so we manage that. We have a lot of undocumented patients that live in South Florida, and that limits their options as well. And then we have those insurance issues, right? Either you have no insurance at all, or you have an insurance that is partially contracted, which means I can do some things, but I can't do other things. And so there's a lot of coordination of care that needs to go with that as well. And then, of course, we've got cultural barriers and language barriers that I'll touch on. And then every patient population has a very different way that they address the way they have their condition, whatever it be. I deal with more patients with have MDS and MDS overlap syndromes and acute and chronic leukemias. And they all handle it very differently depending on where they're originally from. One of the main issues that we have that you see in our community, and I think all over actually, is the financial toxicity that comes with, having cancer. And, many of our patients are the breadwinner of the family. Their main concern isn't, getting the specific treatment that they need for their disease. Their main concern is still being able to provide for their families. And so a lot of what they choose to go with as a treatment modality will go along the lines of, can I take this and go back home? Is it an injection that I can have and go back to work? Is there a pill form of this? And sometimes it's not necessarily the best choice for what they have, depending on the mutational status or the, what's showing on the your NGS studies. So that becomes part of trying to manage their care. And I recently had a patient who had induction chemotherapy for his AML at an outside facility, decided to get his induction chemotherapy straight out, didn't want to get consolidation therapy, went straight back to work. And of course, months later, his disease is relapsed, and now we have to do reinduction therapy. Now we have to get him to transplant, and it's a longer process throughout. So education throughout the process of how to better navigate your disease processes is very, very important. And I touched really quickly on how there are insurance companies that either you have no insurance, B, you have insurance, we kind of take it, but not really, or C, we don't take it at all. And so those barriers, they would rather, a lot of insurance companies would rather you have your condition managed by a community provider. But a lot of these community providers aren't really specialized in aplastic anemia, for example, or PNH, for example, these very rare diseases that need to really be seen by a specialist. And so it can lead, not always, I apologize, it can lead to delays in diagnosis. It can lead to, treatment options being delayed. And then you have those insurances that, don't understand that mutational studies are necessary, because that helps us manage around where the treatment modality would head, or, serial bone marrow biopsies are necessary in certain diseases. They just don't understand. And there's a constant struggle with that with our patients. Supportive care in itself can be very, very challenging. Not only having to deal with the mental burden that you're going through having a cancer and having to manage it in a very different way from a solid tumor, right? A solid tumor, we cut it out, we radiate it, we get rid of it, and you can kind of go on with your life after a certain period of time. With these bone marrow failure type of patients, we're looking at a chronic long-term situation here. We're looking at multiple office visits. We're looking at multiple labs a week. We're looking at transfusion support. And so it's a cultural shift in the way you live your life, really. And so supportive care can be very challenging. Transfusion support is the backbone management of all bone marrow failure patients, and that can be very challenging in certain situations, in certain communities. A lot of community physicians don't have the ability to transfuse a patient in clinic, and everything's sent out to the ER, and you get to the ER, and the ER is like, well, I'm not going to transfuse for that. And there's a lot of back and forth for the patients, which can be very, very challenging. And then, of course, we touched on distance. from the facility and transportation to the facilities. If you look at the next largest cancer center close to us that provides the same type of resources and maybe the same number of clinical trials, you're looking at Moffitt, which is about 4 hours away, which means that we see patients that are anywhere from 2 to 3 hours away from our main facility where our main hematologists are. Trying to get them in for those office visits can be quite challenging. Suggestions for addressing these gaps. I mean, it's an ongoing effort to continually find innovative ways to try to help our population. We do have cancer support services, which provides a lot of the things you touched on earlier, art therapy, music therapy, exercise therapy. We do acupuncture. We have, you name it, we try to address it to provide our patients with support through the system. We also try to involve our social work team as soon as possible, as soon as we recognize that there's a barrier. There are grants from, the PAP Corps, LLS, other communities that deal with bone marrow failure patients that can provide financial assistance. We also have, there are drug companies that can provide either low cost or free drugs to patients that qualify. They help them navigate applying for disability or Medicaid in certain situations. And then they also provide counseling service for mental health concerns where insurance may not cover a psychologist or psychiatrist, but our social work services are free and all of our social workers are licensed counselors. And then, of course, when if a patient is moving over to transplant, our transplant team has a finance advisory team that helps them navigate through how to pay for transplant upfront. So they'll help them with the programs. They'll help them get involved with whatever it is that they need to, so that way they know that if they go into transplant, this is covered by X, Y, and Z. So we do have that in place as well. For patients that have partial coverage, we do what we can. For low-risk MDS patients or a patient with a chronic leukemia that's pretty stable on surveillance, if we have to do labs outside at a Quest facility or something like that, we can opt to work with that, and that's perfectly fine. We also work very closely with some of our community providers. So that way, if the insurance won't allow them to have treatment with us, we can provide a detailed consultation. We write down the entire plan that they can carry out locally with their local physician, and they kind of just refer back to us if something changes. And this helps to cut down a lot of costs for the patients, a lot of time travel, and it's usually a lot more comfortable for the patients that way. So we try to provide that service. I believe our team is actually working on creating a database of our community providers that constantly refer to us, so that way we can streamline that process a little bit better moving forward. For our patients that don't have any insurance or maybe undocumented, we actually work very closely and are affiliated with a local community hospital, Jackson Memorial. And what we'll do is we'll refer patients to Jackson, and they can apply for what is called a Jackson card, which, as long as you provide some proof that you are a resident, you have lived in Miami for a certain amount of time, you're able to qualify for getting free labs, free outpatient care, and free transfusions at one of our Jackson clinics. And this actually works out really well because our hematologists at Sylvester actually round at Jackson. It's our hematologists and our fellows that manage that clinic. So they provide, they are in our tumor boards. They provide, the plan of care. It's the same treatment they would have received if they were at Sylvester, but just in the community setting to make it easier for them. And undocumented patients do qualify for this as well. We also, like Jennifer touched on, we also screen every new patient and every patient that is moving. Apologize, that's my cat. That any patient that's moving into and progressing into disease, we always screen for clinical trials, and we see what is available for them there, because we know that the clinical trials will cover, the treatment. And a lot of the times those clinical trials are a standard of care therapy that we would have chosen for them anyways, plus a new modality that would probably make it better. So we always screen for that. And so, to address the distance barriers, we are lucky enough that we have 9 satellites throughout South Florida, from the Kendall in South Miami to Deerfield Beach, which is in the North Broward area. And so we work very hard to get labs, treatments, everything that we can do in the satellites. I work with Mikkel Sekris, and we prefer to see our patients in person for our office visits, but everything else we try to manage closer to home. Of course, for cultural and language barriers, our team, where everyone's trained in diversity training, there's always language services available throughout the system, whether it be on the call centers or the video chats. There's like a rolling video thing that we do in clinic, but we always provide assistance if there's a language barrier that we need to work with. I think overall, looking for innovative, creative ways to help our population is incredibly important. And I think the most important thing, and especially I touched on, I looked at a couple of the answers on the survey that was provided to us, and a patients just want to be informed. Just talk to your patients in a way that they can understand, with analogies that they can understand. They just want to be informed. You don't sugarcoat anything. We don't sugarcoat anything in our clinic. We tell them specifically what they have, but as long as they're informed and they understand what's going on, they're able to better navigate the system themselves, and better able to help us help them navigate the system. I think clear communication helps to prevent a lot of issues when we're dealing with this patient population.
I was going to add to that, Anastasia. Thank you. I think patients, when they first get diagnosed, are so overwhelmed that they don't even know what questions to ask. So I think it's really an important, as the provider, to help navigate that beginning period and just let them know of what's coming down the road, what to expect, because they have no idea, right? We know they don't understand yet. And one of the other things you mentioned, just in the outpatient setting and even at the NIH, is that thanks to the pandemic, I guess, we've really broadened our telehealth options. And I think that's helped with access for our patients. So especially for our stable patients that are not close by, we do offer a telehealth option when it's indicated, where they can get a lot of the testing done locally and then speak with us as the study team and as perhaps more expert providers in aplastic anemia about what's going on. So I think that's also been something that's really progressed in recent years.
Yeah, I definitely want to agree with Jen about the telehealth. It's one of my favorite things to do when I do that first consultation, to schedule a telehealth visit a week later, so that the patient's at home, they invite the family and friends that they want to be there. And then there's something about being in a telehealth conversation, we're seeing each other, that and it's given the patients time to formulate their ideas, come up with their questions. And then we just have a conversation. And sometimes it's just me reiterating what I said during my first consultation, but this time around, because they've had a week, they're able to take in more of that information. They have their family and friends there with them to ask questions. I always say, the more the merrier, because they come up with unique questions that you as the patient may not think of. And they just are another support, but also another memory bank. As I get older, my memory is getting worse and worse. And so having that additional group of people with you during that telehealth visit really, really helps. So I really love how we're using telehealth more in the healthcare setting, especially, post-COVID. So are there any questions?
We don't have questions that have come in online yet, but we still have a few minutes left. So we encourage people to submit them in either the chat or the question and answer box. You all had mentioned the survey that we had taken, and of course, one of the question or the responses that came up frequently was that just the difficulty of explaining the diseases to family and friends, and understanding what it is that's going on. And all of you touched on how you do that, how, the communication is absolutely key. But are there any other tips that you can add, or things that you suggest that providers do to help patients in that aspect of it, that to help them explain their condition, or their bone marrow failure condition to others?
I think that one of the things that was mentioned was that it is a chronic illness. And I think that's really something that needs to be emphasized, that even if you respond to treatment, there's always that possibility that the treatment could be less effective, or that you might need retreatment, or, sometime along in the future, there might be other challenges. So I think framing it in a chronic disease way is important, because, I've seen a lot of patients that come to us after their initial treatment and their relapse, and they're like, how did this happen? I thought I was cured. So I think in the beginning at diagnosis, that's important. And also just to describe that there is a spectrum of bone marrow failure disease where aplastic anemia could coincide with PNH. Aplastic anemia could lead to MDS or AML. There's things that I don't think are often expressed in fear of worrying the patient, maybe not all at once, but to know the full spectrum of the disease is important.
Yeah, and to touch on that, I think also just reiterating everything at every visit, because you say it the first time and it doesn't kind of click, and you say it the second time and it doesn't click, and so like every single time, and I have patients that have to do that, unfortunately. I'm like, no, this is not going to go away. This is something that it's a chronic thing we're going to have to deal with, and we will deal with it, and we'll deal with it the best we can, but it's not something that's just going to magically go away. And so just gently reminding all the time, because it's necessary. It's, you'll have, family members that come in and out, and they ask the same questions, and it kind of like puts that doubt into the patient's mind. So just, constantly those gentle reminders of, this is what you got, this is what we're dealing with, and this is how we're going to handle it. And it's unfortunately, it's an ongoing thing. So
out of all the diseases I take care of, myelodysplastic syndrome, I think is, easy to explain. But as a caregiver, I feel like paroxysmal nocturnal hemoglobinuria, PNH, can sometimes be the most difficult to explain, because I just want to jump into, medical jargon. And so I definitely have had to practice breaking down PNH, which is, pretty complicated, into, bite-sized explanations to really, explain, how did it evolve, and so forth. And so and sometimes, I have, hunted down really good resources. AAMDS has a great PNH resource that I often will print out, and I will go through it with them and highlight, some of the drugs for PNH, they have really great patient resources explaining how the drugs work, and I will go through that. But I've definitely I've had to develop tools and different, patient information sheets that I've made myself, and I give it not only to the patient, but I will attach it to my note to their physicians in the community, because like I said, many hematology oncologists, PNH is like a blurb that we talk about for 10 minutes during training, and they oftentimes will have forgotten. And so having that information as part of my note to give to their local oncologist, to their primary care physician, and also to their cardiologist, pulmonologist, nephrologist, so that they all know what's going on, has been, a practice to me. So I've, created my own sheets to help break down these, complicated, whether it's PNH, aplastic anemia, or MDS and other bone marrow failure, and those resources, I attach it to my notes. So I'm not just educating the patient and their families, but also their caregivers and their providers back, at home, and always I always leave my email and phone number so that they can reach me directly. Because like I said, there's a lot of, side effects, cyclosporin, there's a lot of medications that interfere with cyclosporin. One of the things I think about is, some of the statin medications, because everybody's on a cholesterol medication, and I'm always having to remind the providers, oh, wait, we can't do this, they're on cyclosporin. So just things like that. And so I've found leaving my phone number, leaving my email address so that they feel comfortable, their providers just texting me, emailing me so that they can make sure that they're not, prescribing medications or something that would interfere with their treatment.
And each of you in your comments today have mentioned how you involve other members of the healthcare team, and you reiterate points and kind of educate every time you're with the patients. How do you encourage patients to ask questions? Like sometimes they can be reluctant to ask, or it's the what's the theory, the door handle theory, where they're waiting until you're done with the exam or the telehealth appointment to ask something. How do you encourage patients to ask questions or to express their concerns about the burdens that they're facing or the obstacles, or perhaps it's other members of your team that bring that out of them if they don't speak with you about it?
I got to tell you the truth. I don't have that problem. Patients are they're talkative, and I like it, and we encourage. And I think it starts from the that new patient visit when you meet me and Mikkel. We're talkers, and we're open and honest, and we encourage them to be the same way. And that initial visit, sometimes they may not have all the questions that they need, and I always let them know at the end of the day, go ahead and write everything down. If it just pops into your head, write it down in a little note. Bring me that list the next time I see you, and we'll address every single one of those concerns. I also provide them with the office number, and they are very, very responsive to our administrative assistant, and they will call with whatever little question that they have. So I think it's just providing them the safe space to ask those questions, to let them know, hey, this is a safe space. You get to ask me whatever you want. My ladies ask me about Botox. They ask me about literally everything. And I want them to feel comfortable coming to me and asking me about those type of things. So just providing that safe space for them to ask, and just letting them know that no question is a dumb question. You can ask me the most random thing, and I'm going to give you, the answer that you need. So I think just providing that culture that they're able to do that.
Yeah, I agree. I think circling back with the patient is important too. So, at the NIH, they meet with a lot of people. It can be very overwhelming, but just, usually the way it works, they'll meet with me and then meet Dr. Young and the team. And then I always go back in and I'm like, how was that? What are your concerns or questions, and give them the contact, make sure I know they have it, but making sure that they know where they have it, on who to reach after their visit if something comes up. But, again, reiterating everything that you go over as much as possible, and, making sure everyone's in touch with the people they need to be in touch with.
I think it's a personal mission of mine to, when I'm meeting new patients, that I'm able to get across to them, the fact that, I am going to be their number one advocate, that I am, going to be their cheerleader and support. And I hope that, by the end of the first and second meeting, they are able to get that, from our interaction, so that they feel very comfortable with me and asking a lot of personal questions. I do things like that telehealth visit, a week after our initial visit, so that they can have family and friends with them. And that's super important, because I want their family, friends, their spouse to be able to have met with me, especially if they weren't able to come to that first appointment, know who I am, know that I am their hematologist, and that I'm going to be there with them through every step of their path, their treatment. And the other part is Epic, the electronic medical record system that we use, has this My Portfolio where they can message. I love it because they can send messages directly to me and, and our team. And it's always so funny to me seeing these messages from 1, 2 a.m. and patients are like, yes, I woke up with this question and I sent it immediately. And so I love, that part of, my job, being able to educate, support, as I get them through their treatment. And like I said, these are patients that I'm going to be with for years to come. And so, making sure that I'm very open and honest, from the get-go, and that they get that across in our meetings.
Well, we have no other questions coming in, so thank you all for a very comprehensive discussion. We touched on all the key points, and we appreciate the different perspectives that you shared and some of the things that you have in common. And there are burdens that all of the patients have, but and the creative ways that you all address them. So we thank you very much for that. And for those online, we encourage you to complete the evaluation from today's symposium, no matter how you were able to participate. All of it will be available on demand afterwards. So, and please share with your colleagues who may not have been able to join us today. So again, thank you all very much to the panel. This is very helpful and informative to our patients and providers. Thank you.
Thank you for having us.
Thank you for having us. Thank you.
Yeah, thank you so much for the invitation.